Meningitis. Meningitis is the inflammation of the meninges, the membranes lining the brain and spinal cord. Pathogenic organisms cross the blood-brain barrier, invade the SAS, subarachnoid space, and cause an inflammatory response. Pathophysiology and etiology. Bacterial meningitis is approximately 3 cases in 100,000 per year. The organisms causing these infections seem to vary depending on the age and immune status of the patient. These organisms may have epidemic potential. There has been a decrease in the incidence of Haemophilus influenza meningitis due to the Haemophilus B conjugative vaccine and an increase in the incidence of Streptococcus pneumonia meningitis. Other common organisms causing adult meningitis include Neisseria meningitis and Listeria monocytogenes. In neonates, L. monocytogenes, that is Listeria monocytogenes and Escherichia coli, and group B streptococci are most common. In patients who are elderly, debilitated, or have immunosuppression, L. monocytogenes, that is Listeria monocytogenes, gram-negative bacilli such as E. coli and pneumococcus may be responsible. Viral meningitis is uncommon in older adult. Cryptococcal and candidal meningitis are opportunistic infections that occur in patients with acquired immunodeficiency syndrome, AIDS, and other immunosuppressive conditions. Cryptococcal infections may be related to exposure to T-gene droppings. Hospital-acquired meningitis frequently associated with neurosurgical procedures is of growing concern. Patients at high risk for sinusitis, otitis media, and pneumonia have a greater risk for developing meningitis. Other factors predisposing to meningitis include alcoholism, cirrhosis, sickle cell disease, splenectomy, and very young and very old patients. Organism colonization frequently precedes community-acquired meningitis, most frequently caused by Streptococcus pneumonia, H. influenza type B, and N. meningitis. Clinical manifestations: headache, fever, altered mental status, confusion in older patients, petechial or purpuric rash, especially with N. meningitis, that is Neisseria, photophobia, knuckle rigidity or a bulging fontanelle in infants, positive Brudzinski's and Kernicki's sign. Brudzinski's sign is place the patient supine and flex the head upward, resulting flexion of both hips, knees and ankles with the neck flexion indicates meningeal irritation. That is Brudzinski's sign. Brudzinskis, Brudzinski's. Kernicki's sign. Kernigs, Kernicki's sign. In this Kernicki's sign also, place the patient in supine, keeping one leg straight, flex the other hip and knee to a bent knee to form a 90-degree angle. Slowly extend the lower leg. This places a stretch on the meninges, resulting in pain and spasm in the hamstring muscle. Resistance to further extension can be felt. Poor feeding, altered breathing patterns, or listlessness in neonates. Onset may be over several hours or several days and vary depending on the infectious agent, the patient's age, immune status, comorbidities, and other variables. Diagnostic evaluation. Number 1. Complete blood count with differential is indicated to detect an elevated leukocyte count in bacterial and viral meningitis with a greater percentage of polymorphonuclear leukocytes, 90% in bacterial and less than 50% in viral meningitis. Normal is 0 to 15%. Blood cultures are obtained. Number 2. Blood cultures are obtained to indicate the organism. Number 3. Lumbar puncture with CSF examination reveals leukocytosis, culture of organism, low glucose levels, high protein levels, and positive gram stain frequently seen with meningitis. A polymerase chain reaction test for DNA is performed to rule out bacterial meningitis. Fourth, MRI CT with or without contrast rules out other disorders. Fifth, low CD4 counts in patients indicate immunosuppression in HIV plus patients and other patients with immunosuppressive disorders. Sixth, latest agglutination may be positive for antigens in meningitis. Management. Acute bacterial meningitis must be differentiated from acute viral meningitis. If there is a greater percentage of polymorphonuclear leukocytes, neutrophils, the patient should be placed on antibiotic therapy for bacterial meningitis. Pharmacotherapy for bacterial meningitis initiated immediately after taking blood cultures is directed at treating the usual causative agents. If meningitis is suspected after neurosurgical procedures, potential IV line bacteremia, CSF leak, or immunosuppression therapy is also indicated for Staphylococcus aureus and gram-negative bacilli. Fifth one, antifungal agents such as amphotericin B and triazoles and fluconazole and itraconazole are indicated for cryptococcal meningitis. Relapse is common if a patient does not have chronic suppressive therapy with fluconazole or another antifungal agent. 20% to 60% relapse will occur. Large doses of IV antibiotics allow adequate amounts to cross the blood-brain barrier. Typical antibiotics include penicillin G, ampicillin, ceftriaxone, cefotaxime, rifampicin, trimethoprim and sulfametazole, vancomycin and chloramphenicol. Antibiotics may be given in combination or singularly. Increasing bacterial resistance to antibiotics has been developing, making the life-threatening illness very difficult to treat in some instances. Pharmacotherapy ranges from 4 days of penicillin therapy with meningococcal meningitis to 21 days in immunosuppressed patients with listeria. Tuberculosis meningitis may be present with cranial nerve deficits because cultures for Mycobacterium tuberculosis take approximately 4 weeks. Empiric anti-tuberculosis drugs must be initiated. Adjunctive therapies to minimize inflammation include corticosteroids, dexamethasone, or hyperosmolar agents, mannitol and glycerol. Report any missed doses of antibiotics, osmotic diuretics, and steroids. Administer PRN dose as soon as possible to avoid deleterious consequences due to missed doses. Complications. Bacterial meningitis, particularly in children, may result in deafness, learning difficulties, spasticity, paresis, or cranial nerve disorders. Number 2. Increased ICP in AIDS patient with cryptococcal meningitis has resulted in severe visual losses. Number 3. Seizures occur in 20% to 30% of patients. Number 4. Increased ICP may result in cerebral edema, decreased perfusion, and tissue damage. Number 5. Severe brain edema may result in herniation or compression of the brainstem. Number 6. Purpura may be associated with disseminated intravascular coagulation, DIC. Thank you.